Can everybody see me? Because I can't see me. Okay. Acha, Bismillahirrahmanirrahim. Assalamu alaikum. So I was given the topic of recent advances in the management, or rather drug management of epilepsy. So inshallah, I think I have 20 minutes.
Ji.
Ji, theek hai, Bismillah. So, well, what I was actually in the recent advances in management, management would be very difficult if we wouldn't understand the new classification. And if we are unable to classify the seizures, everything else, all the advances are actually useless. So the very basics, the very clinical diagnosis of epilepsy is the most important thing. Already, because we've already gone through the classification. I'm not going to, I'll just briefly skip through that. The guidelines have already been mentioned by Dr. Khan as well as Dr. Khalid Sher, as well as, Dr. Nirmal. So we will focus on the new anti-epileptic drugs and briefly go over some of the new surgical options. So the main thing is for our management's sake, we need to know the practical clinical definition of epilepsy. So epilepsy is a disease of the brain defined by any, this is repeating what Dr. Abdul Malik has already told you all. So it's a disease of the brain that is defined by any of the following conditions: at least 2 unprovoked seizures occurring greater than 24 hours apart, or 1 unprovoked seizure, or reflex seizure with a probability of further seizures similar to the general recurrence rate of at least 60%. तो अब जो ये नई जो प्रैक्टिकल डेफिनेशन है इसमें कि अगर एक भी सीजर हो लेकिन आपको साफ वाजे नजर आ रहा है कि इसको दूसरा सीजर पड़ेगा, तो आप दूसरे सीजर का वेट नहीं करेंगे और एंटी सीजर ड्रग्स देंगे या एंटी एपिलेप्टिक ड्रग्स देंगे. ठीक है, अगर कोई एपिलेप्सी सिंड्रोम डायग्नोज हो जाता है पहले ही उस पे, तो ऑब्वियसली आपको पता है कि एपिलेप्सी और आपको उस सिंड्रोम की प्रोग्नोसिस भी पता है, तो उस हिसाब से यू आर गोइंग टू गिव द मेडिसिन. So the other thing that was added here, because we're all thinking, it's a lifelong thing, or is epilepsy resolved in 2 years? We usually give a 2-year cutoff or a 5-year cutoff. So they've actually come up with this, and they say that epilepsy is considered to be resolved for individuals who had an age-dependent epilepsy syndrome, but are now past that applicable age, like absence seizures, like benign Rolandic epilepsy, or those who have remained seizure-free for 10 years with no seizure medicines. With no seizure med. Can you hear me?
जी मैडम, हम हेयर कर रहे हैं बिल्कुल.
अच्छा, there's a lot of background buzzing, so I thought maybe there's something wrong.
ऐसा जरा सबको जरा म्यूट कर दो सवाए डॉक्टर.
जी सर, म्यूट कर दिया सर. वो सडन ज्वाइन किया था तो अनम्यूट से उनको म्यूट कर दिया. डन.
ठीक है, so there should be no, if someone hasn't had a seizure and are off seizure medications for the last 5 years, then they're considered that their epilepsy has resolved. ठीक है, so it's a simple. I'm not going to repeat this. All I do want to show and emphasize is the risk of epilepsy after 2 years. And if you see that if someone is seizure free, have had a first seizure and have remained seizure free for 2 years, then they remain seizure free. And after 2 unprovoked seizures, if they've had 2 unprovoked seizures, then their chance of being seizure free after 2 years reduces. So we usually adopt the 60% cutoff mark. So can a person outgrow epilepsy? We've already discussed that, right? So epilepsy is considered resolved if 10 years seizure free with 5 years of medications. It is a morbid condition, and it does carry a mortality rate with sudden unexpected death, SUDEP, or status epilepticus, which has a high mortality rate, and injury. resulting from the seizure. So those are the causes, main causes of death in epilepsy. And the other thing that this disease does, it carries a very horrible stigma. And when we give our patients a diagnosis of epilepsy, it's like they start gazing at death, that they won't die, but they'll like die otherwise, because there'll be a whole social stigma attached to it. They'll be isolated. They'll have no quality of life. They'll be scared. So all these things together cause depression, anxiety, and obviously pseudo-dementia and cognitive disorders. And then when we give medications, again, they affect the cognition of the person. So these are things we have to consider when we're looking at what we need and what we don't need and what's new. So we'll skip these. And Dr. Khalid Sher has already gone through these guidelines. I'm just going to go with the conclusion only, and that adults with an unprovoked first seizure should be informed that seizure recurrence risk is greatest early within the first 2 years. That's a level A. And clinical variables associated with increased risk may include a prior brain insult, an epileptiform EEG, an abnormal MRI, which is level B, and a nocturnal seizure. So if it's one seizure, but it's nocturnal, it's more likely to seize again than if it's not nocturnal. So then the AN guidelines say that immediate anti-epileptic drug therapy, as compared with delay of treatment pending a second seizure, is likely to reduce recurrence rate. But again, with epilepsy, it still remains that the clinician's recommendations. Every patient is different, and individual assessments that weigh the risk and of recurrence for each and every patient. Okay, so we'll skip these. So one thing that before we go to the newer anti-epileptic drugs and their managements, we need to keep in mind that up to 84% of epileptic patients have at least one medical comorbidity. And up to 64% of epileptic patients have at least one psychiatric comorbidity. 70 to 80% of patients with chronic epilepsies experience cognitive deficits. So we have to keep these in mind when we select our anti-epileptic drugs. What are the advances in management of epilepsy? We have drugs, we have devices, and we have surgery, ablation, lesionectomies, lobectomies, and laser surgery. So, and we have, so the anti-epileptic drugs. So if you can see, and I mean, Dr. Khalid Sher has shown this, and Dr. Tipu Sultan has shown this slide. The third generation drugs, you've all heard their names and everything. What I want to show here is that though we have about up to 20 novel drugs, Pakistan, only the highlighted ones are the ones that we have in Pakistan. Rarely we have some phosphanidone, but Briveracetam has just recently been launched. I think it came in December in one company and January in two other companies. I think it's Brivace, and Briveracetam or something like that. So, and then we have lacosamide, we have pregabalin. Yes, that's abundantly available. And we have oxcarbazepine, which is also available. So these are the four that we have out of 20, which is an unfortunate situation. So now, basically what I'm going to do is I'm going to share this study, which is a real world data on comparing the safety and efficacy of these third generation anti-epileptic drugs. Okay, so responder rates. So they compared 4 of the 3rd generation drugs, which included, so I don't know if you can see the arrow, but the first one is lacosamide. The second one is perampanel. The third one is eslicarbazine. And the fourth one is briveracetam. So 1 and 2 year responder rates. So if you see lacosamide, in the 2nd year, the rate increased, right? So greater than 50% responder rates were noticed. Perampanel also, patient responded and improved. With eslicarbazine, they did the first one, but apparently they never reported their 2nd year results. And with briveracetam, again, we can see that, you know, it gave like 65%, probably the highest responder rate within the next year. So the retention rates at 1 and 2 years during adjunctive therapy. So briveracetam actually came out in 2016. So it's only been here like 4 or 5 years. So, so partial onset seizures from a pooled extension studies of the 4 new AEDs. And these AEDs, again, here is lacosamide, here is perampanel, here is eslicarbazine. Again, we don't have the 2nd year data here, and briveracetam. So if you see that the retention rate of perampanel dropped a lot due to its side effects. And whereas briveracetam and lacosamide kind of are pretty much the same. So the common treatment-related side effects of lacosamide, perampanel, and eslicarbazine and briveracetam, if you can see overall the side effect profile, so orange is perampanel, blue is lacosamide, and yellow is briveracetam. And if you see that overall, the side effect profile is pretty much the same in all of these. There's just a little peak with the perampanel. Dizziness, perampanel had the highest. Lacosamide, obviously, it causes cardiac, it's a sodium channel blocker, and eslicarbazine. So these, and then if you notice that briveracetam is kind of on the low side in all of these, hasn't got major peaks except with the headache. And so it's a favorable side effect profile, not very bad with these. So the clinical efficacy and safety. So this is another trial that a meta-analysis of the randomized placebo-controlled trials. So in total, 15 randomized control trials were included. All the studies contained a baseline and a treatment phase. So the pooled OR of all the newer versus placebo for the response with the 95% confidence interval showed benefit and showed a very good response rate. So the indirect comparison suggested that briveracetam followed by eslicarbazine and lacosamide might be more effective than all the other newer anti-epileptic drugs. So the NNT, so the number needed to treat, the lower the NNT, the better is the efficacy of the response of the drug. So again, you see here of these newer drugs, you see lacosamide has 6.25, briveracetam has 3.85, and the highest here is perampanel. Eslicarbazine and reticabin are pretty much in the same range. But if we look at these, as they concluded that briveracetam seems to be the best where it comes to efficacy. So since briveracetam is a very new drug here in Pakistan, and everyone is curious to see how it does and how it works, I have been using it even before it did come as Breviact when it was launched on some patients, some of my refractory patients, and now that it is here since December of 21. And so what is briveracetam? So the first thing is briveracetam is actually a lecitam derivative. So we have 3 lecitam derivatives: Briveracetam, neutropil or ceremin के नाम से आती है, which we use for anoxic myoclonus, and we use it in stroke patients to improve their speech in children. So that was the first drug that UCP had developed, this lecitam derivative, and then they levodotated it and developed levetiracetam, which had a very good affinity with the SV2A and SV1A receptors, and also calcium channels. And this had a very good anti-seizure. But what was happening with levetiracetam was that it was also giving a lot of cognitive side effects and behavioral side effects, which in real life, and as you know, the use increased, we began to see more and more of it, and we began to see how people would get very restless, would get agitated, and you know, would not respond, would respond inappropriately, would get into fights for no reason, would be irritable, causing, you know, relationships to be difficult, friendships being broken, families being torn apart. So those were things that were there, but it was a very effective, and you know, it did not have any drug-drug interactions, so it was still being used, and it's one of probably the most used anti-epileptic drug, especially here in Pakistan. So Briveracetam is a selective SV2A modulator, and it's the first one that's come to Pakistan. And it's 15 to 30 times higher. It has a 15 to 30 times higher binding affinity with SV2A than the second generation, than levetiracetam, which you know, postulated to uska bhi yahi tha. So imagine if something that's 15 to 30 times more, a higher affinity, so how much better that would be. So it's a third generation for effective control of partial onset seizures with better tolerability. So it claims to have a very good tolerability profile. So the mechanism of action, as I told you, is a lecitam derivative. And since we already have a lot of experience with levetiracetam, I have put the binding and I have compared it with levetiracetam. So here's Briveracetam, so you can see it has a +3 binding here affinity, whereas levi had only a 1, +1. And levi, high affinity calcium channel, had an effect on this. But levi had, you know, would inhibit calcium channel blockers, would inhibit calcium channels, but Brevi does not act on anything else. It's very highly selective. The only one, the first one here. So this is where it goes, right here, and then here, and the post-sign, and kind of closes the post-synaptic. So it doesn't act on the AMPA receptors or anything. Apparently, this is the way it seems to be stopping the seizures. So here we already have a medicine that is pretty much very, very similar in structure to Briveracetam. So what are the differences? So the main differences is Briveracetam has, both of them are rapid and complete, you know, with no food or drug interactions. Levetiracetam and absorption. Permeability, Briveracetam is actually more lipophilic. That means it can more easily cross the blood-brain barrier, and therefore better availability. Distribution, it's totally body water volume. It does not bind to protein. Half-life is 9 hours as opposed to levi, which is 7 hours. Metabolism is primary metabolism for both the drugs is hydrolysis, but secondary metabolism goes through the liver enzymes. IV dosing, infusion is needed for levetiracetam. For Briveracetam, you just give a bolus. So that's another convenience. In renal impairment, you have to adjust the dose of levi. You don't have to do that with Brevi. Hepatic impairment, severe hepatic insufficiency, you have to give a 50% dose reduction of levetiracetam. But with briveracetam, it's a 25% dose reduction in all grades of hepatic insufficiency. So, and that's it. So, levetiracetam versus briveracetam. So, levi-naive. So, levi-naive are those patients who have not taken levi. Is there a clinical benefit for briveracetam? Yes. Previously failed levi? Yes. It does have a higher affinity, so even those who have failed a high dose of levetiracetam should be given a trial of briveracetam. Okay, now, is there a role of giving briveracetam with levetiracetam? No. Concomitant nahi. लेकिन अगर कोई लेवी के साथ बहुत अच्छा कंट्रोल है लेकिन उसका बिहेवियर इशू है, उसको सीजर कुछ नहीं हो रहा है लेकिन उसकी लड़ाइयाँ हो रही हैं, झगड़े हो रहे हैं, या वो बिल्कुल डिप्रेस्ड है, there's a suicidal tendency associated with it as well. तो अगर इस तरह का कुछ आ रहा है तो फिर आप उसको स्विच कर देंगे, आप लेवी से ब्रेवा पे ले आएंगे. तो पोस्टुलेटेड ये है कि इसका बिहेवियर पे बहुत कम इफेक्ट होता है और लेवी इंड्यूस साइड इफेक्ट्स, बिहेवियर साइड इफेक्ट्स जो हैं वो बहुत जल्दी रिवर्स हो जाते हैं और इट हैज अ मूड स्टेबलाइजिंग एंड अ कॉग्निटिव, जैसे पायरासिटैम है ना, वो कॉग्निटिव एमसीआई में भी देते हैं, ये भी पायरासिटैम की तरह इसके कॉग्निटिव बेनिफिट्स भी नजर आ रहे हैं. अगेन रिमेंबर, इट्स ओनली बीन 5 years. वेस्ट में है, हमारे पास अभी आई है. लेट्स सी हाउ आवर पॉपुलेशन रिएक्ट्स टू दिस. तो डॉक्टर निर्मल ने, आई एम श्योर इंडिया में चूंकि काफी अच्छा इसके ऊपर रिसर्च हुई, आई थिंक 8 साल से, इवन आई थिंक यूसीबी फार्मा ने इंडियन एकेडमी के साथ वहां पे रिसर्च भी की थी, इनिशियल सेकंड ट्रायल्स भी आई थिंक हुए थे. बहरहाल, सो ओवरनाइट स्विच है 1-on-1 10:1. अगर 250 BID लेवी ले रहे हैं और साइड इफेक्ट्स हो रहे हैं तो आप 25 BID ऑफ ब्रिवेरासेटाम दे देंगे, ब्रिवेस या जो भी. तो अगर 500 है तो 50 BD, अगर 500 BD है, अगर 1000 BD है तो 100 BD. यूजुअली 200 पे इसका थेरेप्यूटिक बेनिफिट बहुत अच्छा आ जाना चाहिए, 200 milligrams a day, इवन 100 milligrams a day पे भी इसका वो होता है. ठीक है. सो उससे ज्यादा हायर डोज में जो है, अगर आप लेवी हाई डोज के उस पे हैं तो वो करेंगे, लेकिन फिर आपकी जो है स्विचिंग वो 15:1 हो जाएगी इंस्टेड ऑफ 10:1. आई होप दैट मेक्स सेंस बिकॉज दैट्स द सिंपल, इट्स प्रीटी सिंपल, इट्स प्रीटी वो. तो इसके pharmakokinetics, it's highly selective and has a very high affinity for the SV2A receptors. It does not affect the AMPA. It has hypolipophilicity and permeability. ठीक है? It has faster brain distribution. It does not interact with membrane transporters. Potent and broad spectrum seizure suppression in different animal models and has more pronounced anti-epileptogenesis effects than levi in kindling models. ठीक है? The nice thing is it has just recently been approved for the management of partial onset seizures in patients of 1 month of age and above. तो मुन्ने बच्चों को भी आराम से दी जा सकती है ये. Pregnancy category C है, levi की तरह it's presumed to be because structurally it's the same. Pediatric population from 1 month, ठीक है, to onwards. Safety effectiveness established कर दी गई है. It's been approved. Renal impairment में no dose adjustment. Hepatic impairment में all stages just decrease starting dose to 25 BID instead of 50 BID and do not exceed 75 BID. ठीक है? That is 150 milligrams a day. So briveracetam does not interact with other anti-epileptic drugs except you have to keep in mind because ये SVPA पे जाती है तो phenytoin concentrations can increase. तो phenytoin levels अगर concomitantly आप phenytoin के साथ देंगे या carbamazepine के साथ देंगे, क्योंकि partial onset seizures हैं, बहुत सारे patients जो है वो carbamazepine ले रहे होंगे और वो refractory हैं तो आप add on करेंगे. तो इसका क्या होता है कि ब्रिवेरासिटैम जो है वो उसका जो कार्बामेज़ेपिन का मेटाबोलाइट होता है, so it increases its exposure, so then tolerability, drowsiness, encephalopathy और ये चीजें बढ़ सकती हैं इसके एड ऑन होने से। तो इस पे जो है आपको देखना होगा या तो कार्बामेज़ेपिन को कम करें या इसको सोचें देते हुए। राइफैम्पिसिन ऑब्वियसली doses I've already told you about. So it's usually the starting dose is 50 milligrams twice a day or 25 milligrams and then go up. ठीक है, no titration and that is needed. बच्चों में it is 0.5 milligrams per kg to 1 milligram per kg twice daily. ठीक है, और छोटे बच्चों में जो बिल्कुल छोटे जिनकी केजी वाला वेट इतना वो नहीं होता और या फिर इतना कम होता है तो उनको थेरेप्यूटिक इंडेक्स के हिसाब से दी जाएगी। ठीक है, तो now the dosing जो है ना, when you start it you don't need to titrate it, जैसे हम जो वो go slow and start low and slow, इसमें just start what you want to give weight के हिसाब से and hope for the best। ठीक है, अगर रिस्पॉन्स आ रहा है, कम आया है and इसका जो हम 5 days 10 days वेट करते हैं ना रिस्पॉन्स आने का, इसका रिस्पॉन्स हमें नजर आना चाहिए फ्रॉम day 1। That's what they claim. Okay, so key points from the real world data is that briveracetam in real world clinical use is a well tolerated anticonvulsant with 50% responder rates similar to those observed in the regulatory trials, even though 90% of the patients included had been previously exposed to levetiracetam. इसमें बहुत सारे होते हैं जो levetiracetam पे ठीक थे but behavior reasons की वजह से change किया गया। Real world में this is one thing that's one main indication. So data in 262 patients show a retention rate of 75.8% at 6 months and 50% responder rates of 45% and 15.3% seizure freedom for 6 months. So ये add on है, right? Immediate switch from Levi and Brevi, ठीक है, to Brevi is easy. Switch can alleviate levetiracetam induced behavioral adverse events. Main adverse events जो इसके साथ report हुए real world में वो somnolence है, dizziness है और कभी-कभी वो जो Levi induced behavioral adverse events है वो बहुत अच्छी तरह से ठीक नहीं हुए हैं, कम हुए हैं और ये खुद भी इवन अगर लेवी नहीं भी मिली और बिहेवियर कम होने, this too is a lecitan, so it can affect behavior. So it has a very favorable cognitive profile, as I already mentioned, 15% improvement in reaction time and 26% improvement in attention and executive function. And there was no deterioration in verbal word finding difficulties जैसे topiramate वगैरह में होता है। So it's a well-tolerated treatment option for epileptic patients with psychiatric comorbidities. Improvement in irritability and aggressiveness. This was 80%, which is a very good number. And improvement in depressive symptoms was also, 70%. So those are the profiles and the things that are, so we can see in all the trials that, it's well-established clinical data for the efficacy of this drug. It's similar to levetiracetam, which also we have all seen is an efficacious drug. Adverse events, right? जब भी हम किसी चीज की इतनी तारीफें करते हैं, तो there's always something, a caveat behind it. Dizziness, somnolence, ataxia, increase in seizure frequency भी कुछ लोगों ने रिपोर्ट की है। शायद ये कि डोज कम हो, शायद it's just not one, जैसे लेवी से भी कुछ लोग नहीं रिस्पॉन्ड करते। irritability भी obviously की गई है, but not as much, 100 में से 4 ने की है। ठीक है, तो डिप्रेशन, साइकोसिस कम था काफी, डिप्रेशन भी and headache and nausea वगैरह ये चीजें भी, it's a very better tolerated drug, I should say. So in summary, it's effective in Levi-naive patients and those who have had previous exposure to Levi. It's indicated as monotherapy in partially onset seizures with or without generalization in adults and children greater than 4 years of age. And also now greater than 1 month. ठीक है? Next, what's new is the cannabidiol. Again, as Dr. Nirmal had also mentioned, so it's a good option, and a lot of my patients are taking it. They're getting it from US and from Canada, and you know, they've been told, and some get them from other sources, that you know what is the FDA approved and that, but it is FDA approved. CBD oil is FDA approved for tuberous seizures, in intractable seizures, in tuberous sclerosis, in Dravet syndrome, so, and Lennox-Gastaut syndrome. So these are bad epilepsies, and anything that helps should be provided. And I think International Epilepsy Day पे हम ये एक अपील अपने प्राइम मिनिस्टर साहब से और हुकूमत और ड्राइव से करेंगे कि प्लीज इन चीजों को हमारे लिए अवेलेबल कर दीजिए. एक इशू हम ओवरलुक कर जाते हैं. देखें, आप ये देखें कि हेल्प वांटेड गुड मैन, अच्छे लोग चाहिए हमें. भाई मैं अच्छा आदमी हूँ, सॉरी जी, आपका रेफरेंस कहता है आपको एपिलेप्सी है, आप अच्छे आदमी. You know, it's just कि खौफ इतना होता है, नहीं भाई इसको एपिलेप्सी है, हम इसको नहीं रखेंगे, वो एपिलेप्टिक जो है वो भी डरता है ये करते हुए, and you know this whole thing. So we have to stop. You know, आप तो वो कहते हैं कि patients with epilepsy नहीं है, people with epilepsy है, because it's only that brief period of time. उसके बाद तो they're perfectly normal. So then we're almost done. Just surgery. You know, if there is a lesion, it's very easy. You can do lesionectomy and you can remove it. But often, epileptic foci are not visible, not only to the eyes, they're not even visible on the MRI, yet the patient has refractory epilepsy. For that, we need to do corticography. अच्छा, ये सब आगा खान में हो रहा है. मैं जो चीज़ आपको दिखा रही हूँ, ये हम लोग कर भी रहे हैं, डॉक्टर अतरे नाम के साथ, डॉक्टर गौहर के साथ और डॉक्टर ऋषि जुम्मा के साथ. और ये हम लगाते हैं, हम इनको फिर देखते हैं, अंदर मैप करते हैं, you know, seizure zone, और फिर ड्यूरिंग सर्जरी ही हम वो करते रहते हैं, जहाँ जहाँ स्पाइक्स हैं वो रिमूव करते हैं, अवेक सर्जरी करते हैं कि पेशेंट का कोई फंक्शनल एरिया जो है और वो नहीं डैमेज हो और उसकी मेमोरी और सब चीज इंटैक्ट रहे. वी जस्ट रिमूव द एपिलेप्टिक जोन. सो दिस इज अ स्टेट ऑफ द आर्ट सर्विस दैट वी प्रोवाइड. एंड देन अ न्यू थिंग, MRI guided laser surgery for epilepsy has been approved and is being done.
डॉक्टर फौजिया, आपके बस मिनट.
बिल्कुल, बस मेरे पास 2 स्लाइड्स. ठीक है. न्यूरो स्टिम्युलेशन इन एपिलेप्सी, वेगस नर्व स्टिम्युलेटर, डीप ब्रेन स्टिम्युलेटर 2018 में अप्रूव्ड फॉर एपिलेप्सी, एंड RNS. ठीक है. सो दैट्स द डीप ब्रेन, दैट्स द ये, एंड जीन थेरेपी एंड स्टेम सेल थेरेपी. ये सब हो रही है. अनफॉर्चुनेटली पाकिस्तान में नहीं है. हमारी एक्सपेक्टेशंस जो है वो रेवोल्यूशनरी ड्रग के लिए कि दे विल कंट्रोल द सीजर्स दैट एग्जिस्टिंग ड्रग्स कांट एंड वोंट गिव अस साइड इफेक्ट्स. राइट, यही है, नो साइड इफेक्ट्स, नो सीजर्स, तो हम खुश हैं. ऐसी कोई ड्रग है नहीं हमारे पास, अनफॉर्चुनेटली. ठीक है. And I will thank you all for your time and dedicate my presentation as always to Dr. Siddiqqui.